All right. Well, I want to thank you both for joining me on this edition of the ISAPN podcast. So today on this episode, I'm joined by Debbie Broadfield and Susan Swart, who will briefly be introducing themselves. But we're going to focus today on what happened in Springfield, APRN advocacy, patient access, and the road ahead. So with that, I'm certainly, going to turn to my two colleagues here. And Debbie, if you want to go first, and then Susan, introduce yourself second.
Hello, hi, I'm Debbie Broadfield. I am lobbyist for the Illinois Society for Advanced Practice Nursing and happy to be here today to give you a legislative update.
And I'm Susan Swart. I serve as Executive Director for ISAPN. And although my feet are not on the ground of Springfield, I do a lot of more of the back behind the scenes stuff. And I let Debbie do what she does best. And I'm glad to be here as well.
Excellent. So we all appreciate the work that you do for the organization. It would definitely, ISAPN would not be as successful as it is today without the involvement of both of you in terms of your leadership and work on the ground, as you said, Susan, in Springfield. This is going to be a little bit of a longer conversation compared to some of the other podcasts I think we've had because the session was active and we want to give you a good perspective on what happened. And the impact really is larger than one bill. So we're going to walk you through some of the priority bills, bills we supported, bills we opposed, bills that passed, and some that stalled. And then we're going to try to relate that back to what that means to you as APRNs and the patients that you serve. So we're going to start kind of with the big picture. What was this session for ISAPN and nursing from each of your perspectives?
Well, I think for myself, the biggest thing that I think that sometimes gets lost is how much work is happening because we tend to talk about big important bills, big high impact, and then we forget about all the other things that we're doing, the language that we're moving around, the follow up. Debbie and I'll have a conversation and we'll find something that needs to be addressed. And then Debbie has to hit the ground and then we're negotiating on a constant basis, even when it's not our bill. So I think that is the most important thing that I think that our members need to understand that we're not just looking to move the profession forward. We're looking to make healthcare more accessible, more affordable. And what that means a lot of nitty-gritty work. Debbie, what do you think?
Yes, that's exactly right. So every legislative session, there's usually 4,000 to 5,000 bills that are introduced. And I think this particular year, we were tracking more than 250 bills at any given time. It does not mean that we took a formal position on every single bill, but it does mean we're watching for anything that could impact APRNs, RNs, patients, employees, public health, and the broader healthcare system. A lot of the work being done is triage. We are constantly asking if the bill impacts scope of practice, if it changes the Nurse Practice Act, does it affect liability? Does it use physician-only language when APRNs can be included? What about patient safety? Improving access to care. So we are always constantly thinking and of those particular situations when we're looking at bills to see how it would impact the profession.
I think that's excellent to get that kind of feedback. I think oftentimes, as APRNs and as nurses, we're so kind of focused on the little section of healthcare that we operate within. It's easy to overlook all that extra activity that's happening in the background and things that could indirectly or directly impact practice over time if we don't have the surveillance and the oversight that you both bring to the table. So I think the question really has to be more broad than what bill we passed and what bill we opposed, but really focused. And we need to make sure that the membership knows that we're present, we're watching. Debbie, you and Susan are always educating and negotiating, and then working, hopefully. And I think you both have this philosophy, but really across the aisle to protect both RN and APRN practice in the state of Illinois.
Mhm.
definitely is both an offense and a defense. We watch for that very closely. So,
Excellent. So with that, I kind of want to lead into a couple of issues that we wanted to make sure that members were aware of. And so, one of the major ISAPN victories this year was from a prior session and still matters today, and that was House Bill 2688 and Senate Bill 1908. And that looked at the certified nurse midwifery legislation. So this was not a new bill from the session, but really highly relevant. So I was hoping that you each could go through and remind members what that legislation actually accomplished for us.
do you want to go first, Debbie, or do you want me to?
Go ahead. Yeah.
Okay.
Sorry. I'm still kind
Thank
of catching up with, old bills. So,
Yeah. The biggest thing that the CNM bill did is it opened strategically, it opened the door for us to move things in the future. So yes, it did help resolve or I can't say resolve. It helped impact access for maternity care. It opened the door for CNMs who were struggling to find collaborators to be able to practice without those more easily. It opened the door to allow a CNM, so an APRN, to serve as a collaborator of another CNM, which we have not been successful in getting. And that's where we open that door to that possibility.
Mhm.
So we could and do plan when the time is right to swing that door wide open so that all APRNs could choose to collaborate with another APRN. I think that was the secondary win. The biggest piece was the improvement of maternal health care in Illinois, because we know that that is a huge problem. Hospitals are closing, and the CNMs who are offering home births have found it extremely difficult to own their own practices and to do the work because of all of the barriers that were in place. So we cracked through a lot of those barriers. There are still a lot of things that we know we still have to do as far as the rules. I will share with the group that I found out something yesterday. I got an email from someone about some unintended consequences of the CPM bill. If you all remember that, that was where we allowed certified professional midwives to be licensed in the state. Those are non-nurses. And the unintended consequence is that they decided that a report needed to be done by CNM the same way a CPM needed to do it. But now what we have found out is that and this is a required report. So if you did a home birth and you had a bad outcome, and a person had to be transferred to the hospital in an emergency situation, there's a requirement for a report to be done. It was our understanding that that report was only going to be for data purposes. And it has been triggering investigations as soon as that CNM submits that report. They are now being going through that investigative process. And so the CNM bill will use that as a method of, okay, we've expanded, you helped us expand healthcare and access to maternity care, and now we're taking a couple of steps back by following through with this. So it's a never ending. I guess my statement to you is, even when a bill is done, it's not done.
Right. Right. And really and truly, this bill speaks to the really truly towards access, including the federal primary health care professional shortage areas, those HPSA areas that have a score of 12 or higher, and as well the maternity care deserts. So I know that is something that we have been hearing a lot about the shortage of healthcare providers in those areas. And so this bill, having passed last year, even as the conversation was growing, but certainly as it's being part of a bigger conversation now, I think that is a huge success that we were getting a little ahead of the curve of what's really to come.
I think that's great. And I think the real world kind of what happens after a bill or a legislative victory happens really is the take home message here, right? It's operationalizing this. And there are a number of key organizations and individuals that get involved once the bill has been passed out of both houses and signed into law. It's what agencies then oversee its implementation, right? And so that's the next step after this legislative victory has occurred. So, I there are a couple of things I'll want to inject in here at some point, but I want to dig a little bit deeper on some of this just from both of your perspectives because you are the guests on this podcast. So, Susan, why do you think that this bill, you kind of touched on it, but do you want to broaden or elaborate on any other points of where, from the patient's perspective, this bill and this work with the CNMs has enhanced things for residents of the state?
You stumped me, Chris.
You well,
And
that's
it's go.
that is
It's
I
rare.
think
So if
I think if I may say, I think that for patients, I think that it allows them to be able to have births, where their preference is, and also a location closer to home. Not, because of the provider deserts, it answers the access question and knowing that the patients may be hours away from a hospital, and then they can, actually be able to have the birth that they are hoping to have.
Yeah, and good point, because the other thing that it did do, as you were talking, Debbie, it reminded me that it opened the door in the birthing centers as well. And although our birthing centers in the state of Illinois were on a pilot basis for a long time, that was recently changed. But if last count, I believe we only have 6 in the entire state. And so the fact that an APRN and a CNM and an APRN can be lead in those birthing centers, I think that that's going to open the door to solving some of these issues. It also is going to answer that question that Debbie spoke to is I think that as women and their families choose a specific or have an idea of a specific type of birthing experience that they want to have, the state of Illinois has a duty to make sure that we can provide the infrastructure in order for those to happen. And I think removing these barriers continues to do that.
Absolutely. And I'm asking these questions, and Susan, I think what happened there is like you are so close to this and you have been doing this for so long. There's so much information and background, and you just brought up another issue there with these birthing centers, right? So I think it's the proliferation and the ability that it's not really changing what's done day to day, but it really does allow the patients and their families to have more options at their disposal. And these are safe options, right? We know that certified nurse midwives are licensed both as RNs and APRNs in the state of Illinois and in every other state. They have a board certification that conveys to the public they are highly educated, nationally certified, and trained to provide the full spectrum of maternity care. So where appropriate, state law should really reflect removing some of the barriers that allow them to practice to the fullest extent of their training.
Mm-hmm.
Yeah, it
Debbie,
seems
do you want to speak?
disingenuous.
Yeah.
It seems disingenuous, Chris, that on one hand we're opening up the door for other licensees to do the same kind of work, but yet still have barriers in existence. And I know that to be true, not just for CNM, but which we'll be talking about a little later, our CRNA colleagues.
Mm-hmm.
100%. You read my mind, and that is obviously because I am an area of significant passion, and yeah, I'm looking forward to relating some of these legislative successes and wins as really being kind of foundational to looking forward to the future of securing that for CRNAs. Um, Debbie, would you mind just maybe going into a little bit of the liability clarification? I think we covered it, but maybe just a little bit more directly with the
Absolutely.
CNM.
Certainly. The law provides that the physician is not liable for the acts or omissions of an APRN solely because the physician has signed a collaborative agreement, a standing order, or standing delegation order, or any other form of guidelines, except, unless under certain circumstances. But really, it does clarify that even when the law allows for collaboration, a physician may be hesitant, and we've heard that before, to enter into an agreement if they believe they are taking on broad liability for care that they did not provide. The clarification helps, it clarifies that to help reduce barriers.
Yeah, that makes good sense. And the kind of personal or professional lesson I would kind of bring up from my standpoint, being in an operating room and doing anesthesia, is there was this fundamental belief that the surgeon was the captain of the ship. This goes back to like the 60s, 70s, and 80s, where the surgeon in the operating room was held kind of in the eyes of the law across the U.S. to really be in charge of every action that was done. This ranged from the orderly bringing the patient in to the surgical nurse, the surgical tech, and anything that was done. And this over time, as individuals took national certification exams, or licensing became stronger in terms of the caliber and the level that it required of the individual licensee, this really went away, right? So surgeons were not and could not be liable for someone's actions that they didn't directly control, right? So I think in many ways what you're talking about of clarifying liability mirrors that, right? And so now that has been debunked across the country. So, but occasionally you hear, I've heard it from surgeons myself, I am liable for you and the actions you take. And I very thoughtfully respond with, unless you're literally directing me to take an action under your license, you are not, right? I'm licensed and I'm required to be following best practice and evidence-based medicine to be providing the anesthetic I'm providing. So same with the certified nurse midwives. Um, so I don't think this is just symbolic. I think this speaks to a broader lesson, and APRN advocacy writ large here. So, anything else that I'm missing on this topic from either one of you that, from your standpoint, you really want the members to know about?
I just think that it's important that our members and APRNs know what this kind of advocacy does and how it builds upon each other. I think we've talked about that a little bit and mentioned it. And then on top of everything, it's just constant education, right? So for every 5 people that we talk to, there's 5 more who haven't heard about this yet. And if they're not aware, if a patient asks them a question, even if they're not a CNM, they're an APRN doing family practice, and somebody asks the question, and when you're not aware of what the practice looks like, right, it can be an issue. So it is the plus and the minus of the way we've done things in IAPN, in that little bit of chipping away at those barriers one at a time. That education piece, I think, is a huge piece, and it just means being the necessary to be plugged in. You just have to be plugged in. And I'm hoping that as we continue to do more of these open conversations amongst ourselves, that's where we get to.
100%. Debbie, anything else from you on this topic?
I think we've covered it. Yeah.
Good, good.
Yeah.
I want to switch gears just a little bit and talk about a current session bill. One major win was House Bill 1807, which was also connected to Senate Bill 1323. And this dealt with nursing education program reform. So I'm wondering if you could just provide a little update, Debbie, in terms of where that stands today.
Absolutely. Well, very, very excited to let you know that House Bill 1807 did pass this legislative session. It did pass unanimously, honestly, through each chamber. And we had a hiccup last year, but we were able to pass it this year. And bring on additional support from different legislators. It is currently in queue for the governor to sign to take final action, but we do not anticipate any, problems or hiccups with that. So essentially, the bill amends the Nurse Practice Act and changes the requirements for registered professional nursing education programs. It addresses areas and establishes new programs, program policies, faculty training and development, curriculum simulation, accreditation, Board of Nursing approval, program closure, and NCLEX related accountability. So yeah, we were very proud that this passed and happy that it's going to provide transparency more not only for the nurses, but also for the Department of Financial and Professional Regulations.
Excellent. Susan, from your standpoint, why do you think that this bill is so important, even though it's not specifically an APRN scope bill?
Well, I think I can wrap up this portion so that we can get to the exciting stuff about CRNAs here in a moment. But I think that for the simple fact that APRNs are RNs first, and what we were experiencing in pre-licensure programs was an issue, and it was going to be an issue that was going to impact our ability to get more individuals into programs and more diverse individuals into programs. And it definitely, at the end of the day, it's a patient, an impact on safety and readiness. That was a huge issue that we wanted to make sure that we address. Patients need nurses who are educated in programs that have appropriate standards, that have solid clinical experiences, that have good, solid faculty oversight and accountability. And we all know, and we fought for what, 2 years now, Debbie? It took us to get that. We did not think it was going to take that much work.
Right.
That better program oversight helps protect patients from downstream consequences of weak and or fraudulent education. And we know from our colleagues in Florida that experienced that we did not want to see that replicated in Illinois. So this bill takes care of this problem.
Well, and so well said, right? I mean, we're only as good as kind of the individuals that are entering the nursing profession, and the bulk of nurses in the United States are registered nurses, not APRNs. APRNs are a smaller segment, but all APRNs, except for a few states, have to hold both licenses, right? And I think having this focus on program quality, where simulation is used, how much is allowed. I mean, simulation can only really create so much in a program, and we've seen so many changes, I think, in nursing over time, going back to from diploma programs that were centered on highly practical education, where an individual would come out and be capable of being essentially the charge nurse on a unit, all the way to present day, where we have these new grad residency programs that then have to kind of take the new early careerist and then give them even more time to kind of mature. So I think this is a huge win, and I'm glad that we're covering this for the APRN members, letting them know what's also being achieved on the ANA front, and the solidarity between both organizations on these types of issues. Kind of going into another topic here, moving ahead, there was another issue that came up with the Nurse Licensure Compact. Debbie or Susan, whoever wants to lead off here, can we get an update from kind of both of your perspectives on this particular action?
Absolutely. So had House Bill 1706 passed, it would have ratified the nurse compact licensure in Illinois, which would allow for eligible nurses to hold a multi-state license and practice in compact states. For ISAPN members, the bill states that it would not impact APRNs yet, because the bill is simply for RNs at this point. We are Usually frustrated that the bill doesn't move very far. This year, I will say that we did have opportunity to have a subject matter only hearing, even though we didn't have near enough time that we had wanted or needed for testimony. But we had great advocacy and support from nurses in Illinois, all weighing in, supporting it. Um, this will not go away. We will be back again to try to get it passed in Illinois. Um, at least, at the very least, we have some more points and talking points officially on the record, and that we were able to do through the subject matter only hearing.
Excellent. Um, anything that you want to kind of interject there, Susan, or do you want to maybe talk about some of the arguments in favor?
Well, I think, first of all, I think it's important for us to know that APRNs will never have a compact in the state of Illinois until the RN compact comes in.
Yeah.
So, although it doesn't directly impact APRNs directly, it
Mhm.
does impact our future ability to enter into the APRN compact. Um, but when you talk about the in favor of, I think I'm probably one of the lone voices that my biggest concern, and the one that I get so frustrated because we can't seem to get people to focus on this, is that the compact, although it allows nurses to come into the state, it isn't really about the nurses that are going to come in and work in Illinois. It's about protecting the nurses who are already here, who are practicing real world healthcare, which crosses borders every single day. And I'm not sure that most nurses are as in tuned to where their patient is when they're talking to them on the phone and the risks. And I know that because I've had those arguments with nurses who say, well, I do that every day. And I'm like, well, that's great. You're talking to someone in a state where you're not licensed every day. I'm
Mhm.
so glad nothing bad happened, because the moment something bad happens, that's the moment that it matters, right? So to me, those were the arguments. It supports telehealth, it supports real world nursing. And we know that that is the follow-up care. It's not just the care we're providing in the institution, it's the care that happens when the patient goes back home or when they're traveling. And we don't have a resolution to that yet because we don't have it.
Right. I think that's great. I think that what I'm hearing and I've seen is really the continuity piece across care across state lines. And, so much of healthcare has so much of the delivery of healthcare is amenable to telemedicine post-COVID and having, implemented these technological enhancements. And I will say, like, my NP practice, aside from some of the things I've done that have been face-to-face patient care as an NP, a lot of it has actually been telemedicine. So going out and going through the process of getting multiple state licenses, I think, so few of individuals are exposed to that aspect, but having this compact eases the transition. It ensures the continuity with the issuance of a licensure, regardless of where it is. So there's I feel like the administrative burden is much less. And then the thing that I think is most important, I mean, my full-time job is at the certifier. The public wants individuals to know that the licensee and the provider, is doing everything correct, right? So when there is some misadventure or problem with the individual, whether they're impaired or been misjudgment in the past, having that ability to cross state lines with information relating to discipline and other adverse licensure actions is just improving the visibility for members of the public across the United States, right? And we see this with FSMB, the Federal State Medical Board. So physicians are moving this way. It's only natural, I think, that nurses have this type of portability. So I think we hear their concerns. But Debbie, do you want to touch on some of the concerns we've heard, like boots on the ground from people in the state?
Yeah, of course, labor standards, it would diminish state oversight, discipline, education requirements surrounding Illinois law requiring 20 hours of CE, and some of the states do not require any CE. Just in general, how it relates to Illinois specific laws. You know, it's been very frustrating because as we move forward, the goalpost, if you will, for the concerns tend to move forward too, because I think that we always try to rise to addressing the concerns that are out there. Um, but then there's just a new concern that is brought up or born.
Manufactured
I
termite.
Yes. Yeah, that's a better word.
Manufactured.
Yes.
I think that's a little bit about who moved my cheese too. I think
Yes.
that phenomenon of we don't like change and change management is a big part of this particular thing because in my experience with the multiple states and some being compact states, they all manage and are capable of instituting their own state individual requirements atop this, but it
Mhm.
provides a base for everyone to have that portability and visibility across state lines. And you know, if you're not in a compact state, you're going through this FBI background check or whatever state criminal check at each point. I mean, there was a time period when I think I have 14 or 15 state licenses. I literally went and got fingerprinted using the same machine, paying $75 to the same woman, and I did 7 fingerprints, like hands up, hands down, hands up, hands down, and each one went to a different state. And I mean, that's just duplicative, and I actually think that's fraught with more chance for error than actually having one, sending
Mhm.
it to, the one FBI data warehouse, and then having it trickle down to states and have them be able to review it, right? So it's really fascinating, but I have more to come on this, right?
More to come.
Every year.
Cool. I think, of course, this is the passion one for me, and I really I can't thank you enough, both of you and the rest of the ISAPN membership for really championing this and the board because I know that this has been a long time coming and it's been, as you've said, chipping away at multiple impediments and basically I would say more bureaucratic restrictions on practice versus what's actually safe for patient care. But can we talk a little bit about CRNA practice, Senate Bill 239, House Bill 37, and what was highlighted as important CRNA bills? What did they do?
Absolutely. So just to reiterate, ISAPN absolutely, worked to support our CRNA colleagues. The bills that you mentioned addressed anesthesia services in ambulatory surgical treatment centers and hospitals. They would have removed language requiring anesthesia services in ambulatory surgical treatment centers to be under the direction of a physician with specialized preparation or residency in anesthesiology. They would have also removed a requirement that an anesthesiologist participate through discussion and agreement with the anesthesia plan and remain physically, personally present, available on the premises.
Isn't it fascinating how much of a mouthful that is, how that
It
was
really
written
is.
into
Yeah.
law? It's almost like someone did that or a group did that with intent.
Hmm.
Susan, do you want to opine on some of what you see as this issue and kind of what you've seen over time with these types of matters in the state?
So it has been the last few years that ISAPN has become so very involved in making sure that our CRNA colleagues have the same level of practice that the rest of the APRNs have. And I think sometimes for nurses and individuals who are not CRNAs that we forget that CRNAs are APRNs. So how essential they are to surgical and obstetric, emergency dental, pain management, procedural care. When our state law doesn't allow the recognition, a full recognition of a CRNA education and training, it definitely has an impact on access because we know that it is our CRNA colleagues who are working in rural communities, in those smaller hospitals that we have, in those ASTCs, ambulatory surgery treatment centers. And I think what gets lost in the shuffle is how hard those organizations do work to try to have anesthesiologists because of our current legislation, and how difficult it is for them to achieve that. And how much, if we were able to get these bills passed and over the threshold, that would lessen the burden for them and open up the door for more access in our rural areas. And so that is the reason why ISAPN has taken such an adamant role.
And, I think this is fascinating because a couple of things, and I told Debbie, Susan had the ability to meet with one of my local representative here and had a wonderful opportunity to kind of talk for over an hour to her about some of these things relating to anesthesia practice in the state. And I think once people start hearing some of the data points about the workforce shortage in anesthesia, really access to care. It used to just be that if you went to an operating room and you were having surgery in a hospital, physical, hospital setting, that's where you had anesthesia. Right now, to your point, ASCs, GI clinics, a lot of procedures are being done in interventional suites, whether it's electrophysiology or interventional radiology. So less invasive modalities, but still the patient and the system expects that they're going to receive the same level of care, anesthesia care, that they would get in an operating room, right? If they're having a major abdominal or, thoracic or cranial surgery. So really, there's been an increased demand. So I think the question is, how do you expand those abilities to these areas and this greater need without sacrificing quality? And CRNAs have been around for a long time, and I think to your point, we are probably the smallest segment of APRNs. There's people know nurse practitioner and PA because there's more of them. They sort of know midwives because they expect, you call the midwife when you're going to have a baby. So I think anesthesia, it was always like the best kept secret in healthcare. And in the last 10 years, that desire to be the best kept secret has really gone away because people are looking for options when they want to have these procedures, and they want to have comfort and safety at the bedside, right? And so a lot of these things exceed the ability for a registered nurse or a non-anesthesia physician to provide that level of care. So CRNAs offer that. The fascinating thing that we talked about with my local rep was that, and we had one of the lobbyists from IANA there who formerly worked at IDFPR, but talking about that nurse practitioners have had this full practice authority in the state since 2017. And there's been no increase in the number of complaints to IDFPR relating to these licensees. There's been a record of safety, and there's an established playbook that we're now expanding to the nurse midwifery community, which is 2 years and 250 extra CE credits before you're eligible for this full practice authority designation, right? So for those that may have concerns about what this looks like, there's still a structured process for individuals to go through. And I think that early careers always benefits from having, a greater collaborative tribe around them. And of course, I'm obviously could talk about this for way too long, but I will say the other misnomer is the fact that full practice authority means that you're going to work like an independent island provider. That is not reality. That is just crazy because there's no place in healthcare where you're working in anything but a team. Whether you're in a physician's office, a dental practice, hospital. I mean, there are so many team members, and this was the point that I drove home with the representative, right? If you have full practice authority, if you're a licensed independent provider, the expectation is that when the situation in front of you exceeds your capability, you reach out to a colleague and you make a referral to someone who has greater expertise in that disease state or condition. You temporize the situation, right? Because you want to prevent harm. You want to have harm reduction strategies in place, but you're reaching out and you're expanding your capacity by getting referrals to specialists. And this does not take that away, right? So I think that's one of the key elements we have to really get across when we're making these points to legislators and really the community, right? The public deserves options, just like with maternal care. So,
And actually, and I think that, you mentioned that healthcare, well, healthcare is changing. It's changing, in the communities. It's just changing and evolving. And, I know Susan and I are always constantly talking about modernization and, making sure that we are keeping up with the current trends. But that doesn't minimize any patient safety or any care concerns in surrounding what and who people what the training is.
that's a great point. Um, Susan, do you want to just, since you've had this experience and Debbie has too, but and I have not, but I'm close on the coattails, trying to learn as much as I can from both of you. Do you want to touch on the Nurse Practice Act that's sunsetting and just that overall process? Because I think
Sure.
people sort of know, but don't.
Well, I think it's important. I mean, although we were very disappointed that these CRNA bills weren't able to get across the threshold this year, we went into it knowing that the sunset was coming. So the sunset, our Nurse Practice Act, or every practice act in Illinois, sunsets every 10 years. Nursing takes that and runs with it. I just have to be honest. I don't know how else to say it. Because every time the Nurse Practice Act is closed within 2 years of the sunset, we are already beginning building our coalitions and seeking advice from all the different specialties to figure out what do we need to change in our Nurse Practice Act in order to take us for the next 10 years. Because we know that nursing and healthcare is changing that rapidly. So we can't just sit on our coattails and let our Nurse Practice Act just roll over as is, which is what a lot of practice acts do. So we've been doing that work. We've been already meeting all of this year, and with the idea that we will introduce a bill in 2027 that we will begin discussing more than just the CRNA piece. There will be other pieces. There's some language for LPNs that we need to fix because we just fixed the RN education, so we need to match the LPN stuff. There is an effort to make some changes around protecting nurses when they refuse or they say that there's a risk to their patients. So those are just some of the high level things, but it is a big process, and I think if anything, nurses should be aware that not only that this happens, but that when it happens, they have a responsibility to know what's changed in their Nurse Practice Act. And so there'll be a lot of education for that. But Chris, I'm excited because I believe that the CRNA piece as a bigger package, if we don't allow ourselves to become divided, if we are a united front, we are 200,000 nurses. I think that's where we have the most power. If we all stand behind these principles, I think that we're going to get this across the finish line because it'll be RNs, it'll be all APRNs, all working together. All of the four specialties under the APRN all working together. I think that means a huge thing for us as a profession.
I love that. And, that's what the physicians do, right? And other groups, they really do form kind of a solidarity on their collective identity. And they're all across different specialties. And I think nursing has, at times, just missed some opportunity there to really link arms and say, like, this is the same profession. I think, there's a tendency for individuals to say, I'm an APRN, I'm not an RN anymore. The identity is shared, and we really need to kind of tap into that. And so I think when we had Nurses Day at the Capitol this year, that was a fantastic example of really seeing people come together. And the president of the Illinois Nursing Association really he and I, working well together, communicating things and having an open dialogue where he texts me, right? I think that's what we really need to
Yes.
continue to foster. So
Mhm.
I agree. I'm going to make this one quick to kind of save. I know we're short on time here because these things always go longer because we start getting into the things that we're passionate about, we know really well, and we want to convey them to the membership. Um, we did oppose Senate Bill 1482. This was related to certified anesthesiologist assistants. Um, I would just say, one of the key elements here is from a logic standpoint, why introduce, and this is really kind of let's base it in reality here. Why introduce a new type of licensee in a state when you haven't maximized the existing workforce, right? So I think that's where we really have to lean into this.
Okay.
It's not trying to restrict trade or the opportunity for other classes of licensees to exist. But the history for certified anesthesiologist assistants is much newer, and I would say in some form in its infancy in the United States. And we have two tested, proven providers, certified registered nurse anesthetists, CRNAs, or physician anesthesiologists. And so I really think we need to champion the cause here in the state to uh, offer expanded capability and accessibility for CRNA services before we start introducing new groups of people to the table. That's just, I think, good sense, but someone will say something different.
Memorize
We
that one.
fully agree.
So, cool. I kind of wanted I thought we would maybe just wrap up here and maybe leave the membership with some key points about why membership matters in terms of policy work. So, everything we do is centric on membership. When we have board meetings, we're asking questions and saying, you know, um, we've seen a declining membership. How do we bring people back to the table? There's a lot of challenges post-pandemic where people have lost the sense of wanting to go to a physical meeting and share and break bread and be sitting in a common area to consume continuing education. But I think we are seeing people come back to that because they miss it. That human connection just doesn't exist in the Hollywood squares like we're in right now. We do have much more fun when we're together. But we've talked about a lot of bills. We've talked about APRN practice, nurse midwifery, nursing education, CRNA issues. Could you each speak to just really why ISAPN membership is so important to this policy work?
Absolutely. So for sure, membership matters. But beyond membership matters, once you're a member, it's important to be involved. And there are different ways to be involved. Specifically, the one that I'm working the closest with is the Government Relations Committee, and just recognizing that as representing ISAPN as the lobbyist, when I'm in Springfield, and I'm in Springfield every legislative session day to ensure that boots are on the ground in that building, um, representing the views of ISAPN and the positions of ISAPN. And then it is equally important from my perspective because advocacy matters for the members of the association to also be meeting with and building relationships with, like you just said today, Chris, with your district legislators. So it's everything is in tandem and it is all very, very important. Legislators, it does matter to legislators that they hear from their constituents.
And I'm going
That's
to
excellent.
go to a much more practical thing that I talk to people about all the time. Membership and the number of members we have is what allows us to do the work that we do in Springfield. It allows us to make sure that we have the best of the best, like Debbie, with us, and that we have the ability to collaborate and respond quickly when bills move. If we were an all volunteer group and didn't have the financial backing that membership brings, we would be doing this ourselves, which means unfortunately you have the opportunity to miss things. So membership gives ISAPN credibility. and it's credibility in numbers. So when we walk into a legislator's office, we're not just speaking as a single person. It's Debbie's not just speaking what Debbie thinks.
Mhm.
Debbie is speaking on behalf of all advanced practice registered nurses in Illinois who we know, and we have to remind legislators that they are caring for patients every single day. And that is the important thing. And so from a practical standpoint, the number of membership is what makes us able to do what we need to do. And we can't ever forget.
Yeah, couldn't have said it better. And the reality is that regardless of whether someone is a member of ISAPN or not, we are protecting their license, their profession, their scope of practice, and their patients' access to their care. We're going to keep doing that, just like all associations do. Some associations, the CRNA Association used to see 90 to 95% of CRNAs be members, and everyone's been challenged, I think, to reimagine some of the value proposition in the current environment that we operate in. People have choices, they have finite resources of money and time. And, I think what's old is new again. It comes in cycles. So hopefully over time, we see more people come back to this type of organization and say, you know, I wasn't a member for a period of time, but I came to the Midwest conference and now I really want to be re-engaged, right? And I keep saying, like, I'm not going to be here forever. So we need to get new people engaged to really carry the torch. I think we need to really be doing that kind of development work. So I really just want to say thank you to both of you. I think this is a great place for us to end our discussion today because we can only give them so much information in a period of time where they'll have to do what I usually do, which is 2 times speed just to get through it. So I really want to thank you both. Susan, you've been the executive director for the whole time that ISAPN has existed. You are a wealth of institutional knowledge. You are a strategic thinker, and so we are so fortunate to have you in this organization really leading. And uh, I hope that people walk away from this dialogue knowing that even if they haven't met you personally, that they do meet you at a meeting or at the lobby day in the future, because we couldn't do it without you. And Debbie, you know, uh, incredible skill set. And the combination that the two of you bring, it's like 1 + 1 = 4 with the two of you. So thank you both for doing what you're
Thank you.
doing with ISAPN.
Well, and thank you, Chris, for leading us this year. And I'm looking forward to a really exciting 2027.
Me too.
Same,
Thank
same.
you.
Thank you.
Thank you.